This is an hour symposium, obviously, about IRE and pancreatic cancer. I'm Robert Martin from the University of Louisville. I'm going to introduce our first speaker, Peter Hussain, who's an assistant professor of medical oncology and the co-leader of the gastrointestinal program at the University of Miami. He's been a leader, obviously, in pancreatic cancer, but has also been an exceptional collaborator in and around their program, around the use of IRE, specifically with percutaneous IRE. And so he's going to go over the role of IRE in pancreatic cancer. Peter?
Thanks, Rob. Thanks for having me. I think I might be the only medical oncologist in the meeting. So this talk is really not going to talk too much about the technique of IRE, but I'm going to talk to you about our algorithm and how we incorporate the technology in the treatment of patients with locally advanced pancreas cancer. So this is my outline. I'm not going to spend too much time on the background. I imagine most of you already know about pancreatic cancer. We know that it's now the third leading cause of mortality in the US. It surpassed breast cancer this year, and most patients who are diagnosed with pancreatic cancer end up dying from pancreatic cancer. So why are the survival rates so poor? Well, we all know that we do not have any early detection tools yet. Systemic therapy up to this point has been marginally effective due to intrinsic resistance, and more recently we've known about the stromal barrier to penetration of chemotherapy. There's a complex mutational landscape. It's not like breast cancer, for example, where you have intrinsic subtypes which are estrogen dependent, HER2 dependent. In pancreas cancer, there's no specific driver mutation that you can use to divide patients and treat patients with. So we are using mostly empiric treatments rather than specific targeted treatments. And we know, and I'm going to explain this a little more, that dissemination may occur even before you can see a tumor in the pancreas. So also, finally, there's still many oncologists and physicians in the United States today who take a patient with pancreatic cancer and send them directly to palliative care, which may be appropriate in some patients, but a lot of physicians are not aware of the treatment options. So for an audience like this, I don't really need to get into the characterization of the resectability of a patient. So what I'll be talking about mostly is locally advanced unresectable pancreatic cancer, which is obviously stage 3 if you have more than 180-degree vascular involvement of the superior mesenteric artery or unreconstructible common hepatic or portal vein involvement. So the anatomy of the pancreas, I'm going to skip this, everybody here knows that, but we know that the resectability is defined by involvement of the SMA, the celiac, and also the portal vein and superior mesenteric vein confluence. And we are now using more the intergroup criteria, which was a consensus criteria that the Alliance for Clinical Trials group came up with. For the Alliance trial, there was a pilot trial done a few years ago, and now there's a randomized study in progress for patients with borderline resectable pancreas cancer. So we know that borderline resectable is defined as a tumor-vessel interface with the superior mesenteric vein portal vein confluence of greater than or equal to 180 degrees, and it has to be reconstructible. And if you have less than 180-degree involvement of the SMA, that will be borderline resectable. And if you have any reconstructible involvement of the common hepatic or the celiac, that would still be considered borderline resectable. And beyond that would be considered locally advanced unresectable. So this is a picture taken from Matthew Katz's paper when they describe the criteria. And as you can see here on the left panel, there's some daylight between the tumor and the superior mesenteric vein and the superior mesenteric artery. So this will be considered an anatomically resectable tumor. And these are patients who can still be taken directly to surgery. That is still the accepted standard of care. And surgical outcomes, we all know what they are, that most people can achieve a margin negative resection in the patients on the left panel. So for borderline resectable, which is the middle panel, and unresectable in the right panel, surgical outcomes, if you go to surgery first, are not optimal. You have a high rate of margin positive resections if you try to take these patients to surgery first. And obviously these clearly should not be taken to surgery first. We do neoadjuvant treatment nowadays for these two categories of patients. So I'm going to spend a little bit of time talking about how I look at pancreas cancer, and most of you probably already have come up with these ideas on your own. But I put this slide together to show you that pancreas cancer is not the same as other malignancies that we treat. The y-axis here is looking at 5-year survival rate, and these are observed survival rates from the SEER database. And each column represents a stage, right? So the blue column represents stage 1 breast cancer, and then stage 1 colorectal cancer, stage 1 HCC, and you can see there's a drop-off in stage 1 patients. For breast cancer, about 100% of them survive 5 years, whereas for pancreas cancer, stage 1, only about 13% of them survive 5 years. And obviously stage 4, almost none of them survive 5 years. Whereas in breast cancer, about 20% of stage 4 patients can still survive for 5 years. So you're talking about a completely different biology of cancer. And the natural history of pancreas cancer is so short that you don't really have a lot of time to get in treatments that you would normally get in for other malignancies. And this is one of the reasons why there's a big push now to neoadjuvant treatment, because you want to get patients on some form of systemic treatment as soon as possible, because most of these patients already have micrometastatic disease. So we look at pancreas cancer as a systemic disease now. So even though the pancreas tumor may appear localized, if you get good quality imaging, we know that it has already metastasized in most cases. And how do we know that? Well, from the lab, Andy Rim really described this very, very well, where they showed in a mouse model that even when you have PANN, you can detect circulating transformed cells into circulation. Even before these cells become invasive, some of them are already circulating in the mouse. And in this paper, they demonstrated that you had dissemination at a very early stage, even before tumors were clearly visible on any type of imaging study. And then the clinical evidence that pancreas cancer is a systemic disease is that we have a patient, we see patients like this all the time. The patient comes in with a resectable tumor. You have a CT scan, shows absolutely no evidence of metastatic disease. You take the patient to surgery, you take it out, and that patient still has an 80 to 90% risk of recurrence. And why is that? Because the patient already had micrometastatic disease before you take the patient to surgery, and it's just a matter of time before that blossoms and you detect it on surveillance imaging. And more recently, I mean, there are a lot more data for this, but there was a study out of the University of Chicago group, by the GI group there, under Irvin Waxman, who took patients who had resectable tumors, and when they were doing the diagnostic EUS examination, they sampled the portal vein, took blood from the portal vein, and they found that in 100% of patients who had resectable tumors, you could already detect circulating tumor cells in the portal vein, and now we can actually also detect cell-free DNA from the tumor in the blood in most patients who have resectable tumors. So we know that even though the tumor looks resectable, this is already a systemic problem. So again, I don't want to insult your intelligence by putting this slide up, but I want to just give you a framework of how I think about these patients when I see them first, right? So in terms of a therapeutic modality for pancreatic cancer, I would like to present to you a way of thinking about this where it is kind of obvious, but a local treatment modality could include surgery or radiation therapy or some form of ablation therapy. And for me, there are only two types of treatment, right? Systemic treatment and local treatment. And how we sequence those treatments will determine how successful we are. And I'm going to show you some data but on surgery and on radiation therapy and IRE. But you can actually think about it as having those modalities being interchangeable for the purposes of the point that I'm trying to make here. So systemic therapy for pancreas cancer, there's nothing else apart from cytotoxic chemotherapy. There's no targeted treatment that works. There's no immunotherapy that works at this point in time. So we're still stuck with the same systemic cytotoxic chemotherapy that we've been using for a long time. More recently, we've had more tools. And if you look at the median survival times for systemic therapy, in metastatic patients, the median survival for the gem-nab paclitaxel regimen is about 8.5 months. For the FOLFIRINOX regimen, close to 1 year. But we know that even though these are the medians, there's some patients who are outliers. So what I mean by that is that there's some patients who we have with metastatic disease who have prolonged survival, even though the median will tell you that they have a median expected survival of about 11 months. We have patients in our practice who are still alive 3 or 4 years later, having been treated with some of these modern regimens, right? So given those kind of good long-term responders that we've seen in some patients, we're now more enthusiastic to use it. So when I'm talking to a patient about gem-nab-paclitaxel or FOLFIRINOX, I'm not telling them that your expected survival is 8.5 months. I'm telling them that I've had patients in my practice who are alive 2 or 3 years later, having received this regimen. We can't tell up front if you're going to be one of those patients, but we're going to give you the best shot. And if that patient's an outlier, then you may have a chance, if you can control the patient's systemic disease very well, you may have a chance to apply a local modality like surgery or IRE or radiation that might be able to benefit the patient. So I'm going to kind of give some provocative questions here now. Is surgery a good local therapy for pancreatic cancer? So this slide is showing you the survival from the CONCO-01 trial, which is one of the pivotal adjuvant trials in pancreas cancer. And this study took patients to surgery who had resectable pancreas cancer and then randomized them to observation versus gemcitabine monotherapy. So the top line is gemcitabine, and the lower line is a control group. So this is, we can't do this study anymore because we know that adjuvant therapy is effective, but at this time we didn't know that. So we see a control group of patients here after Whipple resection or pancreatectomy for pancreas cancer. And after 1 year, 70% of patients in the control group who receive no further therapy have recurrences. This is disease-free survival here. And after 5 years, 93% of them have recurrences. So what is that telling you? That you can cure 7% of patients with surgery if you don't do anything else apart from surgery. So surgery by itself can cure some patients, but surgery by itself is not enough. So if you add chemotherapy to surgery, then you can increase your cure rate from 7% probably up to 17%. All right, and now with better regimens, we have capecitabine now as a standard of care in the adjuvant setting, which can push this number up to about 25 to 30% cure rate with surgery plus adjuvant therapy. And we're hoping to improve upon that in the FOLFIRINOX studies, which are ongoing in the adjuvant setting now. So again, this is showing you that a lot of patients, 93% of patients in this study who had resectable pancreas cancer already had micrometastatic disease when they were diagnosed. So that those patients had systemic disease. Then this slide always gets a radiation oncologist upset when I talk about this. But the question is radiation a good therapy for pancreas cancer? And I only put one slide here, one study. This is the LAP07 study. But there's so many studies on radiation therapy. And if you look at the highest quality of evidence, the problem is that radiation it's not that radiation is a bad modality, right? We use radiation to cure prostate cancer, to cure head and neck cancer. Radiation works well in tumors which are localized. But the point that I'm trying to make here is that these tumors are usually not localized. So in this particular study, the LAP07 study, they took patients who had locally advanced stage 3 pancreatic cancer and randomized them to receive, they actually got induction chemotherapy first for 4 months. And if you did not progress after 4 months, they were then randomized to radiation versus continuation of chemotherapy. And there was no difference in survival. But the chemotherapy that was used for induction was gemcitabine monotherapy or gemcitabine with erlotinib, which is not very effective as treatment by itself. So the problem here is that not that radiation didn't really help the patients, is that you did not adequately address the systemic problem. This study used inadequate systemic treatment up front. So gemcitabine by itself is not a good induction therapy for any patient with any stage of pancreas cancer because it's just not effective enough. So if you did this same study with FOLFIRINOX, you may have been able to see a benefit with radiation. And you cannot use this study to say that radiation is not effective in pancreas cancer because the study is inherently flawed because the induction chemotherapy was not the best induction regimen. Now we have better regimens. At the time it was the best regimen, but now we do have better regimens. So what if we can control systemic disease? Can we see a benefit from a local therapy? And I'm going to show you some data for that. So the question is there a role for any local therapy in patients with localized pancreas cancer? So I showed you that surgery is not adequate as a single modality. You have to do something else. If you give chemotherapy before, chemotherapy after, you have to give chemotherapy sometime. And radiation therapy, in Europe, nobody uses radiation therapy at all in localized pancreas cancer. In the US, it's still used. There are a lot of people who believe some of the radiation data, so it's still applied in some places. So how can we best select a patient for a local therapy option? And this is where we come in with surgery, radiation, or IRE. How can we select those patients who can benefit from these therapies? So the answer, in my opinion, is to use intensive chemotherapy first. And we published some of our experience here. These are 2 publications that we had. And the second one is the one I'm going to focus on, where there's a series of 50 patients that we treated. All of them were treated the same way. They got induction chemotherapy with FOLFIRINOX for about 4 to 6 months. Some of them got longer treatment than that. And then if the disease remained localized, then we went on to further therapeutic modalities, including radiation, and some of these patients got IRE. So what did we find? Well, first of all, I want to show you that this is a very highly selected group of patients. So in the time frame that we did this study, there were 1,000 patients who came through the door at our institution with pancreas cancer. When you take out the patients with stage 4 disease and restrict it to stage 3 locally advanced pancreas cancer, 194, then those who were candidates for intensive treatment were only 51 patients. This was the study number here. So 5% of all the patients. So this is a very, very highly selected group of patients. But in this group of patients, we were able to see good outcomes. So if you look at the US as a whole, we're talking about a small number of patients overall. So what do we find? Well, when we give patients intensive chemotherapy, even though these patients were deemed unresectable to start with, some of them were converted to resectability. And if they were able to achieve an R0 resection, their survival was longer than patients who did not achieve an R0 resection. So what is that telling us? Well, if we were able to control systemic disease, then you are now able to see a difference when you add a local modality there. So you can substitute R0 resection for something else. It may have been the same outcome if instead of doing surgery, we blasted the patient with a high dose of radiation, or we did IRE. I don't know, but that's possible because we're talking about taking out the residual tumor. You can take it out, you can burn it out, you can electroporate it out. Whatever you do, you're turning now a systemic problem into a local problem, and you may be able to see a survival advantage by doing that. So the principle here is that we did intensive treatment up front, and then we were able to see a survival advantage of doing surgery after that. And what we showed here as well, I don't know if you can see that, but patients who got 12 cycles of chemotherapy, none of them relapsed. And patients who got less than 4 cycles of chemotherapy had a very short survival. So we saw that the intensity of the chemotherapy was correlated with survival. So this tells you that, at least it tells me that you have to give some intensity up front. Because, and what I tell the patients when I'm giving them induction chemotherapy with FOLFIRINOX is not that we're trying to shrink the tumor to get it out. I tell them that we're trying to cure your cancer because I don't really care if the tumor shrinks or not. We can deal with that later on. The surgeons can still do what they need to do. But what will kill them is not whether we can get a tumor, well, if they can get a tumor out, but the micrometastatic disease that you cannot see, and that is what we're using the intensive chemotherapy for. So these are the lessons that we learned, that patients who achieved an R0 resection live longer than those who didn't, and it is likely that intensive chemotherapy was controlling or eliminating systemic disease and now setting the stage for benefit of a local therapy. So this is now our algorithm for patients with stage 3 pancreas cancer. We do chemotherapy first, again, to eliminate micrometastatic disease. This is theoretically what we're doing. And during the period of time when we're giving chemotherapy, we're testing their biology of the tumor. If the tumor responds well, that patient might benefit from surgery or something local. And the physiology of the patient, because if they fall apart after you give them chemo, then they probably would not be able to survive a pancreatectomy either. So now we're using less radiation in these patients. Most times we're going straight from chemotherapy to surgery. And in some patients, we're taking them to IRE. So this is our IRE experience now. We have had 2 publications so far with, well, at least 2. These are the 2 that had original data in them that look at our experience applying the IRE modality after intensive induction chemotherapy. And the first paper had 14 patients in it. The second paper had 50 patients in it. I'm going to go through a couple of the highlights of those papers. So this was a case from the first paper. And you can see here, I don't know how well it projects, but there's a tumor here which is involving the celiac bifurcation. You can see it right there. And this patient had intensive chemotherapy up front, no evidence of disease progression. Then they had a percutaneous IRE procedure. And the next slide is the immediate post-treatment. You can see that the vessel is still intact. And then this is 4 months post-IRE. You can still see some soft tissue enhancement around the celiac right there. And this patient was actually taken for surgical exploration because at this point in time now, it was about a year after the initial diagnosis. The patient had no evidence of disease progression. And the surgeon, who is not in the room right now, but he was able to actually dissect that soft tissue off of the celiac, and it was a margin negative resection. All that was dead tumor. I mean, there was no viable cancer left in that. So this patient was deemed to be unresectable. And even if you look at the post-IRE images, you would still consider that to be unresectable. But the patient had an exploration done and the tumor was removed. So did IRE help with that? Maybe. So at the time when we started doing this, we were using this as a downstaging mechanism or a neoadjuvant mechanism. So the idea was that we would give the patients chemotherapy, and if they remain unresectable, then we would apply this modality and then try to get them to surgery. So this would be sort of a bridge to surgery. And in later experience, what we found was that there were still a lot of patients who were still unable to make it to surgery. And now, actually, we are using it more as a destination treatment for patients with locally advanced disease. Rather than a bridge to get to somewhere, we're using this as the actual final treatment. And we've seen some patients who get this treatment, and they have prolonged survival after it without disease progression. Now, we are obviously still trying to take some of those patients to the OR if we think they're surgical candidates and the tumor might be resectable. So that is still part of the goal of treatment. But now, most of the patients in this series have actually not made it to surgery for various reasons. And we still see good survival outcomes here. So this is from the second paper. The second paper had 50 patients in it, all locally advanced, all stage 3. Nobody had metastatic disease at all in this series. And we saw a median survival of 27 months from the initial diagnosis. So for stage 3 pancreas cancer, if you look at historical series 10 years ago, the survival rates are probably in the range of 12 to 18 months. That's the median survival. Now with FOLFIRINOX, those survival numbers are a little bit longer. There was a meta or a systematic analysis which was published in The Lancet last year, looking at FOLFIRINOX for locally advanced pancreas cancer, and the median survival in that publication with 300 patients from many different institutions was just below 2 years, so about 24 months with modern chemotherapy. So in this series, we found a median survival of 27 months and 14 months post-IRE. So remember, 14 months after the IRE procedure, these were patients who 10 years ago, after chemotherapy or chemoradiation therapy, you would tell them, we have nothing else to offer you. If the surgeon didn't want to take them to surgery for exploration, that was it. You can probably give them more chemotherapy, but then they get burnt out, their bone marrow can't tolerate more chemotherapy, and they would just wait to die. So this is 14 months after you had nothing else to give them. Those patients, that was a median survival. And then the bottom two curves are showing you the separation if the tumor was less than 3 centimeters. So we know that for other tumors like small HCCs, if the tumor is less than 3 centimeters, you have a very high rate of ablating it completely with RFA. So we use that as a cutoff here, and we found that tumors which were less than 3 centimeters in size had a better survival than patients who had tumors greater than 3 centimeters in size, suggesting that the modality itself is influencing the survival rather than just the chemotherapy or whatever they received before. So this is a summary of the data that we have published to date. The procedure was found to be safe. We didn't have any mortality directly associated with the procedure. The morbidity was very low. Most of the patients after the percutaneous treatment went home the next day. Very mild cases of pancreatitis, not significant pain after the procedure. We didn't have any major bleeding or anything like that. So, and these are the survival numbers that I already told you. So we have the aficionado here on open IRE. I'm not going to spend too much time on that, but we have not been using Percutaneous IRE for margin accentuation, but obviously there are a lot of people who are doing that. So, and I'm sure Rob is going to talk about his data. So I have 5 minutes more or less, so probably less than that, but I'm just going to show you a quick case here. So this is a patient who presented to us in September last year. He was diagnosed in 2015 with a pancreas body tumor, 4.3 centimeters. It was involving the celiac, the celiac artery. He had an US FNA confirming the diagnosis, treated with FOLFIRINOX from June 2015 until September 2015, and then he got chemoradiation with Xeloda. He was treated somewhere else. And from December 2015, they just watched him. So he found out about our program. He's a professional golfer. He was traveling around the place. He came to see us in November last year. And initially, we were thinking about doing an IRE procedure for him. We were trying to debate whether we would do this intraoperatively or do it percutaneously. So here's a tumor. He had the splenic vein completely shut down, so he had a lot of collaterals all over the place. And eventually, we decided to do this procedure percutaneously. So that is his pre-treatment PET scan there. For those who missed it, let me show it to you one more time. So the tumor is very avid on PET scan. And this is the probe placement. So there were 2 on top, 2 below, placed actually through the stomach. And this is the post-treatment images, which again showed no evidence of vascular injury. So this was in September of 2016. This is a 1-day post-PET scan. I'm going to show that to you again. The PET scan is almost completely negative 24 hours after the procedure. There's a little bit of enhancement around the rim of the tumor. And this patient has now been followed for the last 6 months. This is a 1-month post-IRE CT scan, which doesn't really show any significant difference in size of the tumor, but there was a PET scan done 3 months later, and the PET scan continued to show no FDG accumulation in the tumor, so he's still on the follow-up. And I'm going to skip this case. It's a metastatic patient, but basically the patient was stable for 5 years, and we ended up doing IRE on him. Even though he had a lung metastasis, we ablated that as well. So in summary, in our institution, we have been applying the IRE modality mostly percutaneously. Now we are doing more open procedures. But we're applying these to patients who have locally advanced pancreatic cancer, who after intensive chemotherapy and sometimes radiation therapy do not have disease progression. And in some metastatic patients who have well-controlled systemic disease with favorable disease biology, we have been using it as well. At other institutions, as you know, it's also used for margin accentuation, and we haven't done that yet in our institution, but it's something we probably will do eventually. So to summarize, local therapies have limited success to date, but that's not because they're bad treatments. It's just that we have had poor systemic treatment up to now, and we're getting better systemic treatment. So that translates into better control of systemic disease, and now you will be able to see the benefit of local treatments such as IRE. And obviously, we need prospective trials to further clarify the role of this therapy. Thank you very much.